Welcome to the Funnel Effect. Today, we're diving deep into a really critical and I think quite complex update in clinical cardiology. We're talking about managing inflammatory heart conditions, our source material. It's the brand new, extensive ESC clinical practice guidelines on myocarditis and pericarditis. We've specifically extracted key insights from the document known as 3EHE192.pdf.
Yeah, this new guideline, it's really a landmark document. It's not just tweaking old advice. It's actually fundamentally redefining how we even think about, diagnose, and manage inflammation that affects the heart muscle and, the sac around it.
Absolutely. And before we jump into the specifics, we really have to acknowledge the massive effort behind this. The corresponding authors who guided this whole process, Jeanette Schultzmenger from Charité in Berlin and Massimo Amazio from the University of Udine in Italy.
That's right. They were the chairpersons. And there were also two dedicated task force coordinators who contributed equally. It was a huge undertaking to create such a unified, specialized framework.
Definitely. So our mission for you today is pretty straightforward. We want you to quickly get a handle on the really big shifts in this framework. We're going to focus on, well, two main things.
Two core changes, essentially. First, the introduction of this new kind of overarching umbrella term. And second, the really significant shifts towards non-invasive methods for diagnosis in the clinical setting.
Okay, let's start with that big conceptual change then, this inflammatory myopericardial syndrome, or IMPS. Before, we mostly talked about myocarditis, muscle inflammation, or pericarditis, sac inflammation. Why bring them together like this?
Well, the thinking behind it comes down to basic anatomy and, frankly, clinical reality. The guidelines really hammer this home. The myocardium, the heart muscle, and the pericardium, the sac, they're right next to each other. They're contiguous structures.
They touch.
Exactly. And inflammation, particularly if it's systemic or, say, viral, it doesn't really care about that neat boundary we draw. Plus, they often share very similar causes, etiologies, think viruses, immune responses. So it's actually quite likely that if you've got inflammation in one spot, the other area probably has some degree of involvement too, even if it's secondary. Using this term IMPS, it forces the clinician right from the get-go to think, okay, I'm dealing with a spectrum here, not just two separate boxes.
That really clicks. It sort of mandates that the initial workup has to look at both structures from the start. And the guidelines lay out this spectrum quite clearly, don't they? From isolated myocarditis to isolated pericarditis.
Right. But the real kind of clinical challenge often lies in the middle, these overlap syndromes.
Yeah, that's where the confusion can happen.
Exactly. And this is where the terminology becomes really precise, and it actually dictates the initial management plan. There are two main mixed forms. And the key difference is whether the inflammation has actually started to affect the heart muscle's ability to pump.
Okay, let's tackle the milder one first.
That would be myopericarditis. So here you have predominant pericarditis. The patient's main symptoms are usually related to that pericardial irritation, chest pain, that sort of thing. But crucially, although their myocardial biomarkers like troponin are elevated, they present without any newly developed left ventricular, or LV, impairment. The muscle might be irritated, maybe a bit injured, but functionally, it's holding up.
Functionally preserved, got it. And the more serious, higher risk scenario.
That's perimyocarditis. Yeah. In this case, the main problem is the myocarditis. The patient has those elevated biomarkers, and they also have newly developed LV impairment, either regional or global.
Ah, so the pump is failing.
Precisely. The presence of that LV dysfunction immediately signals a compromised muscle. It significantly ramps up the risk. It's really the difference between, say, irritation and actual heart failure beginning.
So that immediate distinction, is there LV impairment or not, that's the critical pivot point you need to grasp, because that's going to dictate how you triage them right away.
Exactly right. Myopericarditis, often you can manage it maybe a little less aggressively initially, focus on pain, inflammation, but perimyocarditis, that patient goes straight into the high-risk pathway because you're potentially dealing with heart failure, ventricular dysfunction, maybe even cardiogenic shock.
Right. Let's put some numbers on this. How common are these conditions? Myocarditis, for instance.
Myocarditis isn't exactly rare. The reported incidence is somewhere between 6.3 and 8.6 cases per 100,000 people each year. But one thing that's really consistent across the board, from teens right through adulthood, is that it predominantly affects young men.
Interesting. Any idea why?
The guidelines suggest hormonal factors likely play a pretty significant role. What's interesting is that this male bias, it kind of disappears in very young children, like under 2 years old. It's more balanced then.
And it's fascinating how our ability to diagnose this is changing those numbers, isn't it? The guidelines mention cardiovascular magnetic resonance, CMR.
Oh, absolutely. When doctors start routinely using CMR, which is incredibly sensitive for patients who come in with that angina-like chest pain and high troponin levels, well, the rate of acute myocarditis diagnosis just jumps.
How much of a jump are we talking?
It goes from maybe 5% using older diagnostic approaches up to around 13% when CMR is part of the workup. That's nearly a threefold increase in detection. It
Wow.
really shows that historically we were probably missing quite a few cases of acute myocarditis. And this data strongly backs up the guidelines' big push towards non-invasive imaging.
Okay, switching gears to pericarditis. The incidence seems a bit wider, maybe 3 to 32 cases per 100,000 person years. What's the big long-term headache with pericarditis?
Recurrence, that's the major challenge. The first acute episode, often managed okay, but it comes back frequently. About 20% to 30% of patients, they'll have another episode within, say, 18 months.
Okay, that's significant.
But here's the really concerning part. If you've already had one recurrence, your risk for another one jumps dramatically up to 50%.
50%, wow.
Yeah. So for a good chunk of patients, pericarditis isn't just a one-off thing. It becomes this chronic, relapsing, often quite debilitating condition. And that really underscores the need for dedicated long-term management strategies.
Which brings us perfectly to that core technical change in the guidelines, the diagnostic paradigm shift. Historically, suspecting myocarditis meant, well, getting tissue, right?
Yeah.
An invasive procedure.
Yes, exactly. The endomyocardial biopsy, or EMB, was considered the gold standard for a definitive diagnosis. Now, EMB definitely still has a crucial role, especially in very specific high-risk situations or cases that are progressing rapidly, and we'll get into those details later.
Okay.
But the new guidelines clearly show how incredibly capable our modern non-invasive tools have become.
So multimodality imaging is really taking center stage now.
Absolutely. And CMR specifically is the critical tool. It allows for a clinical, non-invasive diagnosis of myocardial inflammation in the vast majority of patients.
What does that mean practically?
It means faster diagnosis, it means less need for invasive procedures up front, and it means we can start tailored management immediately, guided by what we see on the images, rather than, waiting days for pathology results.
Yeah.
This is arguably the single most important technical update in these guidelines.
Okay, that's a huge shift. Let's move into how we manage this once IMPS is suspected. Timing and risk seem crucial. How do the guidelines classify duration? Acute versus chronic?
Yeah, the timeframes are now standardized for both myocarditis and pericarditis. Acute is straightforward, symptoms lasting 4 weeks or less.
Okay.
Then you have subacute. For pericarditis, they sometimes call this ongoing or incessant. This phase lasts for more than 4 weeks up to 3 months.
Right.
And once symptoms hang around for longer than 3 months, it's classified as chronic. These time points are really important because they guide decisions about how long to continue anti-inflammatory or even immunosuppressive therapies.
And for myocarditis, there's that particularly dangerous acute form you mentioned earlier.
Ah, yes, fulminant myocarditis, or FM. This is truly life-threatening. It's defined by a very sudden acute onset combined with profound hemodynamic instability. Basically, the patient's heart can't maintain circulation on its own.
So they need support.
They need significant support.
Yeah.
We're talking inotropes drugs to make the heartbeat stronger, or even mechanical circulatory support, like an ECMO machine, just to stay alive. This is an immediate, all-hands-on-deck ICU situation.
Got it. Now, let's talk warning signs, the red flags highlighted in Table 6. These are the things that should make you suspect IMPS and trigger that urgent workup.
Okay, the first thing, often shared between both, is what happened just before the heart symptoms started. A recent flea-like illness, maybe a bout of gastroenteritis. The guidelines note this precedes cardiac symptoms in something like 80% of acute myocarditis cases. It really points towards that infectious or post-infectious trigger.
Makes sense. What about the really high alert flags specifically pointing towards the myocardium being involved?
These are signs the heart muscle itself is in trouble. So infarct-like chest pain, pain that mimics a heart attack, new or rapidly worsening heart failure symptoms, like sudden shortness of breath, what we call dyspnoea, unexplained fainting or syncope, or documented dangerous heart rhythms, like sustained ventricular arrhythmias, VA.
And lab tests or initial imaging.
Definitely. Persistently elevated troponin levels are a big one. And then on initial imaging, like an echo, seeing abnormal wall motion or overall reduced pumping function, impaired systolic function, those are major red flags. They tell you the muscle's function is compromised.
Okay. And the pericarditis red flags, also in Table 6. These seem more about inflammation and the mechanical effects of fluid.
Exactly. You're looking for that classic pleuritic chest pain, the kind that gets worse when you breathe deeply or lie flat. Hearing pericardial rubs with a stethoscope, or, if enough fluid builds up, signs of right heart failure because the sac is starting to squeeze the heart.
And systemic inflammation.
Yes, a significant and ongoing elevation of systemic inflammatory markers is key, especially C-reactive protein, CRP. While it's not specific just to pericarditis, CRP is elevated in maybe 80% to 90% of significant cases. It's a really strong indicator of active inflammation in the pericardium.
Recognizing these flags then pushes you straight into triage and risk stratification, covered in Table 7.
Right.
Why is getting this risk level right away so vital?
Because it dictates the level of care needed immediately. If you miss a high-risk feature, that patient could deteriorate incredibly quickly. It could be fatal. So risk assessment determines, do they need the ICU right now? Do they need an urgent biopsy, mechanical support? Or can they be managed more safely on a general cardiology floor? It's about resource allocation and patient safety.
Let's detail those high-risk features for myocarditis. Who needs the most aggressive approach?
Okay, high-risk myocarditis includes anyone presenting with acute heart failure or actual cardiogenic shock, anyone with sustained ventricular arrhythmias or VF ventricular fibrillation, high degrees of heart block on the ECG, or a significantly reduced left ventricular ejection fraction, LVEF, below that 50% mark.
And the recommendation for these patients?
For anyone with these features, immediate admission, usually to an intensive care or coronary care unit, is a Class I recommendation. It's non-negotiable. Their survival really depends on rapid diagnosis and how well they respond to initial treatment.
What about the low-risk myocarditis patients? You mentioned they're the majority.
Yes, about 75% of unselected acute myocarditis cases fall into this category. They're generally stable, maybe just have some chest pain, or what we call oligosymptomatic, few symptoms. Crucially, their heart function, biventricular function, is preserved. No sustained arrhythmias, maybe some transient ECG changes.
So better outlook.
Generally, yes, a more benign prognosis. But admission should still be considered, it's a Class TI recommendation for initial observation, monitoring, making sure nothing changes. They just don't typically need that immediate intensive workup like the high-risk group.
Okay. And finally, for pericarditis, what flags mean hospitalized now because of high complication risk?
For pericarditis, the high-risk features are a kind of checklist for severe underlying causes or mechanical instability. Things like a high fever over 38 Celsius. A subacute onset, meaning symptoms developed more gradually, which often suggests a tougher course. A large pericardial effusion, defined as more than 20 millimeters on the echo.
So significant fluid.
Right. Or the presence of actual cardiac tamponade, CTP. Another flag is if they haven't responded to standard therapy after at least a week. Also, any sign of coexisting myocarditis, or if the patient is immunosuppressed or if there's recent trauma, any one of these puts the patient at higher risk for bad outcomes, making hospitalization a Class I recommendation. Got it. That triage is critical. Let's dive into the tools actually driving this shift. Multimodality imaging is key, starting with the first test usually done, transthoracic echocardiography, PTE.
Yeah, TTE is essential. It's non-invasive, it's fast, widely available. It gives you that immediate look at heart function, chamber sizes, and crucially, pericardial effusion fluid around the heart.
What does it show specifically in myocarditis?
Often you might see global dysfunction, meaning the whole heart isn't squeezing well, or maybe just specific areas, regional wall motion abnormalities. But importantly, even if the overall ejection fraction, the EF, looks okay, TTE can pick up subtle signs of damage.
Like strain.
Exactly. Reduced global longitudinal strain, GLS, or global circumferential strain, GCS. These strain measurements are more sensitive ways to assess muscle contraction. They can show early injury and reduced efficiency even before the EF number itself starts to drop. It's an early warning sign.
And for pericarditis, TTE is the go-to for effusion size and complications. Absolutely. Let's just classify the pericardial effusion, the PIF. Mild is less than 10 millimeter, moderate is 10-20 millimeters, and large is over 20 millimeter. And critically, TTE is how we spot that mechanical emergency cardiac tamponade, CTP, by looking for signs that the heart chambers are actually collapsing under the fluid pressure. You can also pick up early signs of constriction.
Okay, moving to the powerhouse. Cardiovascular magnetic resonance, CMR. You called it the cornerstone for non-invasive diagnosis of myocardial inflammation. Why is it so highly recommended?
It gets a Class I recommendation because it does something unique. It combines fantastic anatomical detail with the ability to characterize the tissue itself. It's the gold standard for measuring function in both ventricles and, crucially, for detecting subtle signs of inflammation and damage within the heart muscle. The non-invasive diagnosis hinges on the updated Lake-Louise criteria, or LLC.
Okay, the Lake Louise criteria. Can you break that down for us? There's talk of T1 and T2 criteria.
Sure, think of it in two parts, reflecting different aspects of the injury process. The T2-based criteria are all about detecting active inflammation and water content edema. When tissue is acutely inflamed, it holds more water, and T2 sequences are sensitive to that.
Right, water content.
Then you have the T1-based criteria. These focus more on detecting actual injury, fibrosis, or scarring. The main way is through late gadolinium enhancement, or LGE. Gadolinium contrast agent gets trapped in areas of scar tissue, making them light up on the scan.
Okay.
Another T1 method is quantifying the extracellular volume, or ECV. This gives a measure of more diffuse, spread-out scarring across the muscle, not just focal spots.
So how do you use these together for diagnosis?
The updated guidelines say for a clinical diagnosis of myocarditis, you ideally need at least one T2 criterion showing that active edema and at least one T1 criterion showing the injury or scar, like LGE or increased ECV. Though sometimes one criterion in the right clinical context might be enough. Being able to quantify that diffuse fibrosis with ECV mapping is a really big step forward. We're moving beyond just looking for obvious scars.
And that LGE finding, the scar itself, you mentioned it carries significant prognostic weight, especially depending on where it is.
Yes, this is a critical insight for managing patients long term. The location of the LGE is hugely important. Specifically, LGE found in the mid-wall of the anciseptal segment, that's the middle layer of the wall between the ventricles, towards the front. That pattern has been identified as the single best independent predictor of major adverse cardiac events, or MACE.
MACE includes things like
Cardiac death, appropriate shocks for an ICD, basically bad outcomes. And specifically, that mid-wall anoseptal LGE predicts sudden cardiac death, SCD, with a really high hazard ratio, or HR, of about 4.59.
wow, an HR over 4.5. That's a massive risk increase. Finding that pattern should really change things for the patient.
Absolutely. When a clinician sees that specific scar pattern on the CMR, it signals a chronic risk of dangerous arrhythmias, even if the overall heart function, the LVEF, seems to recover later. That patient can't just be discharged and told they're fine.
So what happens then?
They need close long-term follow-up, and likely an immediate referral to an electrophysiologist, an EP specialist, to properly assess their risk for needing an implantable cardioverter defibrillator, an ICD. Even if the ICD isn't put in right away, maybe waiting for inflammation to settle, the discussion has to happen. It just highlights how powerful CMR is, not just for diagnosis, but for stratifying future risk.
Makes sense. With CMR being so central, when does computed tomography, CT, come into play?
CT gets a Class I recommendation for specific structural questions. It's excellent for looking at pericardial thickness, really important for diagnosing constrictive pericarditis. It's also great for spotting calcifications in the pericardium, or masses, or loculated effusions, pockets of fluid that might be tricky to see otherwise.
Any other uses?
Yeah, it's often used early on, especially if the patient presents with that infarct-like chest pain, to quickly rule out coronary artery disease as the cause, because the symptoms can be identical to myocarditis.
Okay. Now, even with all this amazing imaging, we can't completely forget about getting tissue samples. When is endomyocardial biopsy, EMB, still considered mandatory, a Class I recommendation?
EMB's role has become much more focused. It's Class I recommended mainly for those high-risk myocarditis presentations, patients with acute heart failure, hemodynamic instability. Also for intermediate-risk patients who just aren't getting better with standard treatment after a reasonable time.
And the goal isn't just confirm inflammation anymore.
No, the goal now is much more specific. It's about identifying particular histological subtypes of myocarditis.
Why is nailing down the exact subtypes so critical?
Because the treatment can change dramatically. It might pivot from just supportive care to needing aggressive, targeted immunosuppression immediately. For instance, you need the biopsy to diagnose things like giant cell myocarditis, GCM, or eosinophilic myocarditis, EM. These are absolute medical emergencies requiring specific drug therapies right away.
Okay.
EMB also allows us to look for viral genomes using PCR, helping identify a cause, and it helps distinguish inflammatory cardiomyopathies from non-inflammatory mimics, like certain inherited heart muscle diseases.
And when the pathologist looks at that tissue, what are they actually measuring?
It's become quite quantitative. For diagnosing inflammatory subtypes, they use immunohistochemistry. For example, to confirm lymphocytic myocarditis, they need to find more than 7 CD3 plus T lymphocytes per square millimeter, plus the presence of CD68 plus macrophages. It's very specific.
And timing matters for biopsy.
Hugely. Especially if GCM is suspected in a high-risk patient. The guidelines stress that doing repeat biopsies can significantly increase the sensitivity up to 93% because the inflammation can be patchy. And that tissue needs to be analyzed urgently, ideally within 8 hours, because a positive result for something like GCM means life-saving treatment has to start immediately.
Wow, 8 hours. Okay, let's shift to a field that's really growing. The genetic connection mentioned in recommendation table 2. It seems the guidelines are now acknowledging that inflammation might interact with underlying genetics.
This is a really important and expanding area. We're finding a significant overlap between genes that code for structural heart proteins, things involved in desmosomes, which hold cells together, or sarcomeres, the contractile units, in cases of acute or even recurrent myocarditis.
How common is this link?
Pathogenic or likely pathogenic gene variants, PLP variants, are being found in a surprisingly high percentage of complicated myocarditis cases, somewhere between 22% and 45%. The idea is that the inflammatory event might act like a second hit that unmasks a pre-existing, perhaps silent, inherited cardiomyopathy like ARVC or dilated cardiomyopathy, DCM.
So who should actually undergo genetic testing in the context of IMPS?
The guidelines now give it a Class 2 recommendation in several situations. If there's a family history of IMPS, cardiomyopathy, or sudden unexplained death. If the patient themselves presents with severe ventricular arrhythmias, or if they have persistent problems with heart function, like a low EF or significant LGE on CMR, especially certain patterns like ring-like or septal scarring.
And for pericarditis?
For pericarditis, genetic testing should be considered mainly in those really stubborn, refractory, recurrent cases, the ones that just don't respond to standard treatments like colchicine. This might point towards specific monogenic autoinflammatory diseases like familial Mediterranean fever, FMF, which have their own targeted therapies. Identifying these genes is crucial because, again, it changes the long-term risk assessment and management plan, potentially tipping the balance towards needing an ICD sooner if a high-risk genetic substrate is found.
Fascinating how genetics is weaving into this. Let's focus now on those specific high-risk myocarditis subtypes where getting that EMB diagnosis quickly is truly life-saving. Starting with giant cell myocarditis, GCM, the prognosis sounds terrifying.
It really is. GCM typically hits young to middle-aged adults and progresses incredibly rapidly. Historically, before we understood the need for immediate aggressive immunosuppression, the median survival time was shockingly short, maybe around 3 months, from when symptoms started until death or needing an emergency heart transplant. Even now, mortality remains very high.
3 months. So delaying treatment isn't an option. What do the guidelines mandate in recommendation table 16?
Immediate combined immunosuppressive therapy. It's a Class I recommendation. This needs to start the moment GCM is strongly suspected, sometimes even before the biopsy results are back, if the clinical picture is grim.
And what does combined therapy involve?
It means high-dose corticosteroids plus at least 1, and often 2, other potent immunosuppressive drugs like calcineurin inhibitors, for example, cyclosporine or tacrolimus. The aim is to hit that destructive autoimmune attack hard and fast, trying to shut it down immediately.
Okay, next up, cardiac sarcoidosis, CS. You called it the great mimicker.
Yeah, because CS is a systemic disease causing granulomas, clumps of inflammatory cells that can infiltrate the heart, but its presentation is incredibly varied. It can look like ARVC, DCM, sometimes even hypertrophic cardiomyopathy, HCM. Often, patients might actually have normal or near normal overall heart function initially.
So how does it usually present then?
Frequently, the first signs are electrical problems caused by granulomas disrupting the heart's conduction system. Think sudden high-grade atrioventricular blocks, AVBs, needing a pacemaker, or dangerous ventricular tachycardia, VT.
How do you pin down the diagnosis when it can look like so many other things?
It really relies on a combination of advanced imaging, which gets a Class I recommendation. First, CMR is key for that detailed tissue characterization, finding the pattern and extent of LGE, the scarring. Second, FDG-PT scanning is crucial.
Why FDG-PT?
Because FDG-PP detects active, metabolically hot inflammation. It can show where the inflammation is currently active in the heart, and very often it picks up involvement in other parts of the body, like lymph nodes or lungs, confirming the systemic nature of sarcoidosis. And that LGE burden seen on CMR, especially if it involves the septum, is a very strong predictor of bad outcomes, particularly future ventricular arrhythmias.
And given that high risk of sudden cardiac death, SCD, management has to be proactive, right?
Absolutely. Corticosteroids are the first-line treatment to try and cool down the inflammation. But because the risk of SCD remains high, some studies showed up to 31% at 5 years. An implantable cardioverter defibrillator, an ICD, gets a Class I recommendation if the patient has had sustained VT or VF, or if their LVEF drops to 35% or below. It's a two-pronged approach.
Yeah.
Treat the inflammation and protect against sudden electrical events.
Makes sense. The final high-risk subtype is one we're seeing more of with modern cancer treatments. Immune checkpoint inhibitor, or ICI-induced myocarditis.
Yes, this is a relatively new but devastating complication of certain immunotherapies used to treat cancer. It's highly unpredictable and incredibly severe. The guidelines highlight the mortality rate. It can be as high as 50% for patients who develop it.
50%? That's staggering. When does it typically occur?
Usually very early after starting the ICI therapy. The median onset is around 30 days. And the risk seems to be highest when patients are receiving combination ICI therapies, using more than one agent.
The urgency here sounds like it rivals GCM. What's the immediate response required according to Recommendation Table 18?
The response has to be immediate and aggressive. Number 1, stop the offending ICI treatment immediately. Number 2, administer high-dosage corticosteroids immediately. Both are Class I recommendations.
Stop the drug, hit it with steroids.
Exactly. You have to try and halt that runaway immune reaction right away. The guidelines also stress that the diagnostic workup needs to be completed super fast within 24 hours of suspicion. If the patient doesn't respond well to the high-dose steroids, if they're steroid refractory, then second-line immunosuppression is needed, often involving things like high-dose intravenous immunoglobulin, IVIG, or therapies targeting T cells. This is a true medical emergency requiring a coordinated multidisciplinary team, an MDT, from the very beginning.
Okay, let's shift our focus now to pericarditis. Here, the main challenge often seems less about acute heart failure and more about managing that persistent or recurrent inflammation. What's the cornerstone of drug therapy based on Recommendation Table 10?
Colchicine. It's strongly recommended, Class 1, as an add-on therapy to standard anti-inflammatories like aspirin or NSAIDs, ibuprofen, indomethacin, those sorts of drugs.
Why colchicine specifically?
Colchicine has anti-inflammatory effects that seem particularly well suited to the mechanisms driving pericarditis. Its main benefit is significantly reducing the risk of recurrence, which is key. Remember that 50% recurrence risk after one recurrence. Using it in combination helps get patients into remission faster and allows the NSAIDs or aspirin to be tapered off more slowly, hopefully minimizing their side effects too.
We talked about being cautious with steroids. If that first-line combo fails or the case is incessant or keeps coming back, how do the guidelines view corticosteroids now?
They're still seen as a double-edged sword. Yes, they give rapid symptom relief, which can be tempting, but they're also strongly linked with increasing the chance of recurrence later on and potentially prolonging the whole course of the disease, especially if used in high doses or tapered too quickly.
So, avoid if possible.
Generally, yes. They should really only be considered if the patient absolutely cannot take NSAIDs or colchicine, or if that first-line therapy has definitively failed after an adequate trial. They're not a go-to first option anymore.
Okay, so for those really tough, refractory, recurrent cases where the inflammation just won't quit, what's the next step?
For these difficult situations, the guidelines now recommend considering anti-IL-1 agents. This is a Class I recommendation. These are biological drugs like anakinra or rilonacept.
How do they work?
They specifically target interleukin-1, which is known to be a major cytokine driving the inflammation in certain types of recurrent pericarditis, particularly the autoinflammatory ones. This treatment should be considered when there's evidence of persistent inflammation either through clinical markers like CRP, even if it's only slightly elevated, or ideally, confirmed by imaging findings on CMR showing ongoing pericardial inflammation. The fact that you might use it, even if CRP is normal based on CMR, shows a move towards more personalized, targeted anti-inflammatory therapy. It's a big advance for these patients.
Beyond the drugs, one practical aspect that's really tough, especially for younger, active people with IMPS, is the need for physical activity restriction.
Oh, absolutely. And it's essential. During the acute phase of both myocarditis and pericarditis, restricting physical activity is critical to minimize stress on the heart muscle and reduce the risk of triggering dangerous arrhythmias or worsening inflammation.
How long are we talking?
For myocarditis, it's often recommended for 3 to 6 months, followed by a careful assessment before resuming activity. For pericarditis, the restriction is usually needed while symptoms are active. If symptoms like chest pain persist mainly because the inflamed layers are rubbing, the guidelines suggest that beta blockers or algabradine might be considered. Not to treat the inflammation itself, but to lower the heart rate if it's consistently high. say over 75 BPM at rest. The idea is that a slower heart rate might lead to less friction between the pericardial layers and potentially reduce symptoms.
Interesting mechanical approach. Let's talk about the scary complications. Cardiac tamponade, CTP.
Right, CTP is when fluid builds up so much in the pericardial sac that it physically squeezes the heart, preventing it from filling properly. This leads to circulatory collapse. It's a true emergency.
How is it diagnosed?
Diagnosis is primarily clinical. You look for the classic signs known as Beck's triad: low blood pressure, hypotension, raised neck veins, jugular venous pressure, and muffled or distant heart sounds. This clinical suspicion is then confirmed immediately with TTE, the echocardiogram, which will show the heart chambers collapsing under the pressure.
And the treatment?
Urgent, life-saving pericardiocentesis. That's draining the fluid with a needle and catheter. It's a Class I recommendation and should preferably be done under imaging guidance like echo or fluoroscopy for safety.
Okay. And the chronic complication is constrictive pericarditis, CP.
Yes, CP is when the pericardium itself becomes thick, scarred, fibrotic, sometimes even calcified. It loses its elasticity and essentially encases the heart, restricting its ability to fill with blood during diastole. It's like the heart is trapped in a rigid shell.
How is CP managed?
If CP is newly diagnosed, the guidelines recommend trying a course of anti-inflammatory therapy first, usually for about 3 to 6 months. This is important because a significant minority of cases, maybe up to 30%, might be what's called transient CP related to ongoing inflammation and could actually resolve with medical treatment alone.
But if it doesn't resolve?
If it's clearly chronic CP, or if it persists despite that trial of medical therapy, then surgical pericardiectomy is needed. This is a major operation to physically strip away the thickened, scarred pericardium to free the heart. It's a Class I recommendation for chronic symptomatic CP.
Lastly, what about long-term follow-up and prognosis based on Table 15?
For uncomplicated first-episode pericarditis, the prognosis is generally excellent. Most people recover fully. However, for those with incessant or recurrent pericarditis, long-term follow-up is strongly recommended, Class 1, to monitor for symptoms, ongoing inflammation, and crucially, to watch for the potential development of complications like constrictive pericarditis over time.
And for myocarditis follow-up?
The guidelines are quite specific here. Repeat CMR within 6 months is recommended. This follow-up scan is absolutely vital for several reasons. It helps guide the decision about when it's safe for the patient to gradually return to exercise and sports, and it provides critical information about long-term risk. The prognosis really hinges heavily on whether the left ventricular function, the LVEF, has recovered back to normal by that 6-month mark.
That 6-month CMR seems like a really key checkpoint.
It absolutely is.
Okay, the sheer complexity we've just discussed, needing specific immunosuppression, interpreting advanced imaging like CMR and PET, understanding genetic risks, it really highlights why the guidelines put such a strong emphasis on an integrated multidisciplinary approach, the MDT. This isn't just a nice-to-have, is it? It sounds essential for a complex IMPS.
That's exactly right. It's mandatory, really. Think about diagnosing giant cell myocarditis. You need that biopsy result interpreted correctly within hours, and then immediate coordination to start multi-drug immunosuppression, or deciding about genetic testing and whether an ICD is needed. No single doctor, no matter how skilled, can optimally manage all aspects of these complex cases alone. Collaboration is key.
Let's unpack who needs to be on that team for the complicated cases, as shown in Figure 20.
The core MDT will vary a bit depending on the case, but essential members usually include the clinical cardiologist managing the patient day-to-day, an imaging specialist, particularly someone expert in CMR who can really interpret the nuances of the Lake Louise criteria and LGE patterns, and critically, a specialized cardiac pathologist who can accurately interpret the endomyocardial biopsy findings.
And beyond that core?
Depending on the suspected cause or complications, you'll likely need input from a rheumatologist or clinical immunologist to guide specific immunosuppressive regimens, maybe an infectious disease expert if a virus is suspected, a clinical geneticist to advise on testing and family implications. And then you need the specialists who manage the downstream complications. Electrophysiologists for arrhythmias and ICDs, interventional cardiologists for procedures like pericardiocentesis, and cardiac surgeons for things like pericardiectomy, or in the worst cases, heart transplantation assessment.
That's a lot of specialist expertise, likely concentrated in bigger centers. How do the guidelines suggest making sure patients everywhere can access this level of care?
They strongly advocate for a hub-and-spoke model. The large tertiary referral centers, the hubs, have the advanced infrastructure. The top-end imaging like CMR and FDGPT, the the specialized pathology labs for EMB, the capacity for mechanical circulatory support, and complex surgery.
And the spokes.
The regional or local hospitals, the spokes, manage the majority of the straightforward, uncomplicated IMPS cases. But the crucial part is that they need to have clear pathways and close collaboration with their designated hub. Any patient who presents as high risk from the start, or an intermediate risk patient who isn't responding as expected to initial therapy, needs to be promptly transferred to the hub for that specialized diagnostic workup and management. This networked approach is vital for ensuring equitable access and improving outcomes for everyone.
Right. So if we were to synthesize everything we've covered in this deep dive, the key takeaways really paint a picture of completely modernized care for these conditions.
I think they do. First, just recognizing IMPS as a spectrum is fundamental. It ensures you're thinking about and assessing both the pericardium and the myocardium right from the beginning. Second, the diagnostic approach has truly shifted. Non-invasive multimodality imaging, especially CMR, is now the absolute cornerstone for diagnosis in most cases, and it's also critical for determining risk.
And the third point.
And third, for those high-risk or complex cases, management must be individualized, often urgent, and guided by an experienced, specialized multidisciplinary team working within that kind of networked hub-and-spoke system. The whole framework is really designed to diagnose faster, treat smarter, preserve heart muscle, and ultimately save lives.
That sums it up perfectly. As we wrap up this deep dive, let's circle back to something we touched on briefly, that mandatory rest period, especially after myocarditis. Medically, we know why it's needed, right? That 3 to 6 months of avoiding significant exertion is crucial to let the heart heal and minimize the risk of long-term damage or sudden death.
Absolutely. The medical rationale is very clear. However, the guidelines do make a point of acknowledging a really significant consequence that perhaps we don't always focus on enough during the acute chaos,
Yeah.
the psychological impact.
Tell me more about that.
Well, think about it. You take someone, often a young, previously healthy, active person, and suddenly tell them they have a serious heart condition and have to stop all strenuous activity for months. It can lead to intense frustration, anxiety about the future, feelings of social isolation if they can't participate in sports or activities with friends, and sometimes significant depression.
Yeah, I can definitely see that being incredibly difficult.
So the real challenge for the MDT and for clinicians managing these patients long-term, it goes beyond just the heart muscle. It's this constant balancing act, upholding the clear medical need for rest while also recognizing and addressing the very real mental health burden this restriction imposes. How do we support patients through this? How do we engage in shared decision-making about return to activity that considers both physical safety and mental well-being?
That's a really important point. It suggests future research maybe needs to look not just at optimal restoration, but also at strategies to proactively support patients' mental health during that recovery period.
Exactly. It's a powerful reminder that truly comprehensive patient care has to look at the whole person, not just the affected organ.
Indeed. We've certainly covered a tremendous amount of new ground from these guidelines today. Thank you for watching The Funnel Effect.